Okay, let's get back into the notes about how we get the venous blood back to the heart. Because I just told you that by the time we get to the right atrium, the pressure inside that vessel is 0 millimeters of mercury. That doesn't mean the vessel's empty. It just means that this is such a flabby structure that as you fill it up, it just doesn't really make a big change in its pressure inside that. And I always want you to associate a pressure number with flow, because these pressures in are indicative of flow, and that's why we talk about this thing called, oh, darn it, I did it again, mean arterial pressure. Mean arterial pressure is kind of like the average speed limit that the blood is flowing through the arterial system. And so whenever you have a nice mean arterial pressure of like 90 or 93, you're having what is considered normal blood flow through your arterial system. And remember, it's the diastolic plus 1/3 the pulse pressure. So if you have high blood pressure, such as 150 over 100, then the diastolic that we would add would be 100. So we're already over the normal mean arterial pressure plus 1/3 of 50. So what? 115, 120. And so mean arterial pressure really does tell you a lot about the stability of the system, because the higher the mean arterial pressure, it's kind of like the faster you go in a car. Your chance of death increases the faster you go, right? So the chance of death from a higher mean arterial pressure does increase because it's a hypertensive phenomenon more often than not. And then if your mean arterial pressure is low, that also is indicative that your chance of perfusion because of blood flow speed is also diminished, and so that affects your longevity. So mean arterial pressure is a good number to tell you the overall well-being of the flow through the arterial tree.
So that's the good stuff. Diastolic.
Diastolic.
1/3 the system.
1/3 the pulse pressure. Yeah, 1/3 the pulse pressure. And the pulse pressure is systolic minus diastolic. And so it's because you spend more time in diastole than you spend in systole, right? We've already went through lumped up, right? Lumped up and double up. You know, lumped up is systole and diastole is double up. You spend more time in diastole because you need to have adequate ventricular filling. So factors aiding venous return are really, really important, and it's all related to, right now, most of your blood is getting back to your heart because of what we refer to as the respiratory pump. So let's go ahead and go over, you inhale. Well, when you inhale, we will get more venous blood returning to the heart. And it does it via two mechanisms. It's the diaphragm. The diaphragm, when it's relaxed, is dome-like. So it's attached to the inside of our body cavity, but it's dome-like. Just like what you found with your cats, right? Wasn't the diaphragm dome-like in your cats? So that's what it's like when you're not inhaling, when you've actually exhaled. So that's a relaxed muscle. So when it contracts, it flattens. And so when it flattens, just like you found the liver was right underneath the diaphragm, correct? It's going to push everything down. What's that going to do to the intra-abdominal pressure? It raises it up. And because our veins have valvular systems designed to help blood flow only one direction, which is back to the heart, it compresses those vessels and literally causes the milking action of the blood going back towards the heart. Even though our pressure is increasing in the abdomen, it's helping to squeeze the blood upwards towards the heart. So that's one thing about the diaphragm. Diaphragm contracts. This will increase intra-abdominal pressure and therefore milk the blood in our veins toward the heart. Now, the thorax is a closed space, and when we inhale, what did I do to the volume of this closed space when I had my diaphragm go down? It increased it, and it is indeed a closed space, and so therefore, what happens is we create a bit of a vacuum effect, and that's actually when we get into our respiratory system, that's actually how we bring air into our lungs. So you have to remember, you have a space, and it has so many air molecules in it. And however many, we'll just say air molecules for right now, and however many air molecules you have in that space exerts pressure on the walls, right? Well, now I made my space bigger, and now my pressure is less, right? So the space is bigger, the pressure is less, and so it's almost like, that's why I say it's like a suction, because isn't suction going to cause, when you suck on things, what direction does the stuff you're sucking on go? In. Okay. So inside your mouth, that's a negative pressure, right? When you create suction. And so this system is like suction. And what's really interesting about it, it literally helps to suck the blood back towards the heart. So sucks the venous blood back to the heart. It will plus increase intrathoracic volume, which causes a decrease in pressure, which pulls or suction blood in the vessels in that area So IVC and SVC, for example, which pulls blood into vessels in that area. So it's a very effective pump. So inhale or inhalation, more venous blood is going to return to the heart. So exhalation is going to be the opposite. So as you read through the respiratory pump in this diagram, one of the things that I want you to understand is that I want you to know that not everything in a book is correct. And so the explanations in here increases blood flow to the heart and things along that line. I want you to remember what I told you, not what this chart tells you. So I want you to take inhalation, what I told you, and exhalation, what I told you, not what this is telling you. The muscular pump is referring to the valves in the veins that are surrounded by muscles. And so when the muscles contract, they're going to squeeze on the veins, and they're going to also help promote the return of venous blood back towards the heart. And that's what we mean by the muscular pump, not the heart muscle. We are talking about skeletal muscles for venous return. Blood is squeezed back to the heart because of the valvular system. And remember, these valves are constructed like the semilunars. Now we're going to go to the topic of cardiac output and things that can affect blood pressure. Cardiac output, remember, is stroke volume times heart rate. It's the amount of blood pumped by the heart in 1 minute. Okay. If we increase our cardiac output, such as what happens when you're exercising, right? When you exercise, what happens to your heart rate? Goes up. So we're increasing our cardiac output, and indeed, because of that, it will cause an increase in our blood pressure. So it's always nice to actually check your blood pressure when you're sitting and relax, and then check your blood pressure and see how much it actually does go up as you exercise. Now, the more athletic you are, the less elevation you'll get. The more deconditioned you are, the greater the elevation that you will get. And the reason for that is the athlete's heart rate, A, will not increase as much as a deconditioned individual, and they already have a good stroke volume that doesn't need a lot of augmentation to this. And just to ask you a question, when you exercise, what happens to your respiratory rate? It goes up, which means your venous return goes up. That's right. So it's really a cool system. I really think so. Then peripheral resistance, factors affecting blood pressure. Peripheral resistance indeed will affect your blood pressure. So the smaller the diameter of a vessel, the more the peripheral resistance. BVE is my abbreviation for blood vessel. Increases peripheral resistance. And what will this do to blood pressure? Think of blood in vessel upstream. If you are squeezing down on a tube and the blood's coming in one direction, so now upstream is where the blood came from, what are you doing to the volume of blood in that tube that you're now squeezing down distally? It's increasing, and that too will increase the blood pressure. The interesting thing is if we double the radius, which is vasodilate a blood vessel, you will decrease resistance 16-fold. So doubling a BV blood vessel radius decreases resistance 16-fold. In other words, it's 1/16 what it was. Increasing your blood volume. Well, you have a nice salty meal like I did the other night. What do you think happened to my blood pressure not long after that, even though I was in a profound, great state of rest digest? Yeah, so my intravascular volume did increase. And isn't that another reason why they tell people with high blood pressure, decrease your salt intake? They're trying to find out if they are salt sensitive. If you decrease your salt intake, if you're salt sensitive, you will actually decrease some of that intravascular volume that is pushing out on those vessels, contributing to your high blood pressure. But only 1 out of 10 people, I hate to tell you, are salt sensitive. So this is always just a temporary phenomenon for most of us. We have a high salt meal, we drink more fluid, and then our kidneys take care of the rest and pee that stuff out for us and take care of it. So increasing blood volume increases indeed blood pressure, and our example is salt intake. Cause is temporary for the bulk of us. How does our system actually normally regulate our blood pressure? And the predominant mechanism is via the central nervous system. And it's easiest to regulate blood pressure by changing diameter of those little itty bitty arterioles, because they are going to be like what I was just talking about, a tube, and at one end we clamp down the pressure and suddenly we get backup, and that will increase our blood pressure. And if we dilate the arteriole, we'll get a significant decrease in blood pressure. But that's the main mechanism that our body actually utilizes via the nervous system, telling our arterioles, the little guys before the capillary beds, that we will vasodilate or vasoconstrict. So that's even without those precapillary sphincters is what I'm talking about. So yeah, that's way before that. In the nervous system, we actually do have a vasomotor center, and it's in the medulla oblongata. And we have neurons that fire on a spontaneous basis to maintain our baseline blood pressure. And because they fire spontaneously for us for a regular rhythm, that is referred to as vasomotor tone. And it's constant partial arterial vasoconstriction, because the neurotransmitter that is actually being released is norepinephrine. So NE for norepinephrine. And norepinephrine, all by itself, is a potent vasoconstrictor. Now we're releasing norepinephrine at the tunica media. So if we're only releasing a little bit of norepinephrine, we're more dilated, and the more norepinephrine we release at the tunica media, the more constricted we are, and therefore the higher the blood pressure will be as we go upstream. And isn't that where we measure blood pressure, right? We measure it upstream. We don't measure it close to the capillary beds. We measure it from the big vessels. Vasomotor fibers here, it states sympathetic efferents, and that's part of our regulation of our blood vessel lumen is the sympathetic nervous system, and norepinephrine is that neurotransmitter, innervating our tunica media and causing that increase neurotransmitter output or decrease based upon what it is that our vasomotor center is regulating for us. Baroreceptors. We talked about these previously in the carotid sinus and the aortic arch. We call those areas carotid bodies and aortic bodies too, just in case you might run across that in literature or old notes. Indeed, mechanoreceptors are also pressure receptors. They respond to stretch and things along that line. And so remember, we have those located in our aortic arch, carotid sinus, in various bodies. And if the pressure is too high, going to our brain, it reduces our heart rate. And when we reduce our heart rate, we decrease our filling of the vessel, correct? And that also will decrease blood pressure. Increase heart rate, increase cardiac output, increase blood pressure. Decrease heart rate, decrease cardiac output, decrease blood pressure. And that's something that happens all the time when we lay down. We're going to decrease our cardiac output. When we are standing up, we're going to increase it, because when we're laying down, we're not as active, correct? So do you need as much cardiac output when you're not so active? So all of these centers are all regulated actually in a very reasonable way to help us maintain the activity that we need to undergo. Chemoreceptors are also located in our carotid sinus and the aortic arch, adjacent to these carotid bodies and aortic bodies. These chemoreceptors respond to O2 and CO2 levels. And CO2 is more important, actually, than O2, because CO2 affects your blood pH. What will increase your blood carbon dioxide levels? Breathing rapidly or holding your breath? holding your breath, right? Breath holding, or holding your breath, actually increases carbon dioxide, because why do we breathe anyway? When we breathe in, we want oxygen. When we breathe out, we want to get rid of carbon dioxide. So those things that you learned are still true. We're not changing that story. So if you're holding your breath, that means you're not releasing carbon dioxide to the external environment, which means carbon dioxide levels build up. So let me ask you, I'm telling you it's related to pH, and what do you think holding your breath and therefore carbon dioxide levels building up does to your pH? Does it make you more acidotic or alkalotic? Carbon dioxide goes up, but I will tell you, when it does so, it will actually create a chemical reaction where we get more protons. When we get more protons, are we acidotic or alkalotic? Acidosis. So what's important for you to fix in your head right now, carbon dioxide going up is inversely related to our pH. You guys follow me with the word inversely? If something is going up and we have an inverse relationship, the other thing is going down. Okay, so our CO2 levels and blood pH are inversely related. So when CO2 levels go up, our pH goes down. The pH is what the brain pays attention to more than anything. Blood pH is very, very important to the brain. One of the things to remember, we have a very narrow pH that we function at, 7.35 to 7.45. So blood pH is very important, and when we're at 7.3, we're acidotic because we're retaining carbon dioxide or we're undergoing a metabolic acidosis. The thing that's, now that I've gone through all the stuff about carbon dioxide and oxygen pH, the important thing to realize is the chemoreceptors don't really work on our cardiovascular system. Not much of an effect on cardiovascular system. Big effect on respiratory rate. So if you're acidotic, what do you think an acidotic person is doing to compensate for that acidosis? What do you think their respiratory rate is doing if for some reason they're acidotic? It's going up. They're trying to compensate for that acidosis, and that's why people who have diabetic ketoacidosis, it's a metabolic acidosis, and so your body tries to compensate for that by creating a respiratory alkalosis. And typically it's failing, because that's why you're in the emergency room. Higher brain centers affecting our blood pressure. Well, indeed, the hypothalamus is in control of so many things, and it is important because it is going to regulate any additional information that goes to the medulla oblongata, which is where our cardiovascular centers are actually located. So it indeed controls that sympathetic fight-flight because we talked about ANS there, and it will have input to the medulla oblongata. So if we're having issues, the medulla oblongata will actually be stimulated more to actually increase heart rate and blood pressure, cardiac output, etc. Hormonal controls. So the majority control is nervous, and hormonal controls are there to modulate. So that's why we have the word short-term effects. These hormones that I'm going to talk about are typically only dumped into the system for a limited amount of time and then not. And so it's designed to actually kind of modulate things a little bit, and they won't have that long-term effect on things as you are used to with actual endocrine systems that we've talked about in the past. The adrenomedulla hormones, we commonly call that, again, adrenaline. That's epinephrine and norepinephrine. And so when we are hormonal, that means we're dumping adrenaline into the bloodstream. And norepinephrine is a very potent vasoconstrictor, so we'll get vasoconstriction for a period of time, increasing blood pressure. Epinephrine also causes vasoconstriction except in our skeletal muscle blood vessels. And if we're in fight-flight mode, those skeletal muscle blood vessels will need to vasodilate to actually feed those skeletal muscles to help us create enough ATP to get out of danger. Another hormone that is often referred to also as an enzyme is angiotensin II. You'll see it listed in the previous notes as angiotensin, and its actual correct name is angiotensin II. It too is a very potent vasoconstrictor, and in addition to causing vasoconstriction, it causes the release of aldosterone and antidiuretic hormone. Both of those are designed to cause us to retain fluid, right? Aldosterone causes sodium retention and water retention from the kidneys, and antidiuretic hormone also does the same thing, causes us not to make more urine, causes us to make less urine, which is a fluid retention process. And so that's why in our notes here it says causes kidneys to retain water. Well, it's this guy and this guy. So it's not just antidiuretic hormone. Aldosterone also does the same thing. And the more fluid we retain, therefore, the more increase in blood pressure we will experience. Therefore, cause BP to go up. ANP, atrial natriuretic peptide, is also a hormone produced by the atria. PD is produced. And it is designed to get rid of Na. When I say Na, what does that mean to you without looking at the notes? Sodium, that's right. So atrial natriuretic peptide is going to cause sodium to go into the urine and also water to go into the urine. And so this will cause a decrease in BP because of sodium uresis. And uresis is we're dumping it into the urine, and when we dump it into the urine, water also follows. So that was decrease intravasc volume with this process. The kidneys are pretty important to controlling our blood pressure, and we see in their long-term regulation. So those hormones are more for a short-term process. The kidneys, however, have a long-term regulation of our blood pressure, and that's why people who have kidney failure also happen to have high blood pressure, unless they're getting dialysis, and then because we sucked all the fluid out of them, then they have low blood pressure, and so their blood pressures are going up and down all the time. And so that's why they want transplants, right? Because they don't like the feeling of up, down blood pressure. Kidneys affect intravascular volume directly by the amount of urine they create. So directly by the amount of urine they create. So they control urine output, and that's a direct effect on your intravascular volume and therefore on your blood pressure. They control our blood pressure indirectly via a hormonal mechanism in that they, when we get more into kidneys, we'll talk about this in more detail, release this hormone / enzyme, because what happens is an enzyme cascade. They release renin, and the renin-angiotensin-aldosterone system gets turned on. By the release of renin, we will then create angiotensin II, which will then impact aldosterone release. So angiotensin II is a very important chemical that stimulates aldosterone release. Another thing that stimulates aldosterone release under ordinary circumstances, remember, is high blood potassium levels. The other thing that will stimulate aldosterone release is a drop in blood pressure. So the adrenal glands, and this is in the cortex, is helping your blood pressure. But aldosterone all by itself isn't a potent savior of blood intravascular volume. And so with this kidney release of renin, it will cause the formation of angiotensin II, and also that will stimulate aldosterone. And I just told you earlier, angiotensin II causes also the release of antidiuretic hormone. And all of these are going to cause fluid retention, which will increase intravascular volume, and then we will increase our blood pressure via this mechanism. An important stimulus for the kidneys to release renin is a drop in blood pressure.
Is renin what gives our urine its yellow color?
Is renin what gives our urine its yellow color? No, it is not. I'll be honest with you, I don't remember what gives our urine its yellow color. I'm only interested in asparagine giving our urine greenish color.
Well, I know as you get more dehydrated, your urine is going to get that deeper yellow stuff.
Yeah, the deeper color. There's a lot of other factors that will give you more amber or even a yellow, orange kind of urine. And some of that is actually even red blood cells actually in the urine from overnight sleep and position changes. There's a lot to it. We're not going to go there. Okay, blood flow. Let's take a look at cardiac output, because blood flow and cardiac output are pretty synonymous to me. And realize that the brain, for its size, gets 13% of our cardiac output. Our heart only gets 5% of the cardiac output. The kidneys, which are big regulators of our intravascular volume, get 20% of the cardiac output. Our digestive tract, under ordinary circumstances, gets 25%. And then our skeletal muscles get 20%. If you add this up, it will not equal 100%. And so we're missing things like from our skin, as well as our lungs. There's, things along that line. But these are the percentages I want you to keep in mind. Digestive tract gets the most. Kidneys are in competition with skeletal muscle. Isn't that fascinating? All that large skeletal muscle mass and all those two little beans, they get the same amount of cardiac output. And then the brain is next in line, and the heart's the last one in line as far as percentage of cardiac output goes. We come to a story about velocity of flow. Speed of flow of blood is fastest in the aorta and slowest in our capillaries. And that's good, because in capillaries, that's where we want to have nutrient and waste exchange occurring. And it does this so by a simple diffusion process, and simple diffusion takes time. So we do want the blood flow in our capillaries to be the slowest, because we need to actually have the nutrient and waste exchange occurring in our capillary beds. The speed, even though we talked about low millimeters of mercury in the venous system, after we slow down to a crawl in the capillaries, we will actually pick up again in the veins, and a lot of that's due to that respiratory pump helping to suck the blood back to your heart. So that's kind of a nice thing about that. One of the things to realize is with this velocity of flow, it's inversely, again that inversely word, related to total cross-sectional area. So you have to realize that if we were to cut across all of the teeny tiny little capillaries in your body and put them all together, we would actually end up with an area of about 4,500 square centimeters. So capillaries. Excess cross-sectional area, approximately 4,500 centimeters squared. You guys remember the size of the aorta on your pig heart? Was it about that size? Yeah. And that's what it is for us. So that aorta is about 2.5 centimeters squared. And then the veins, and we'll say vena cava, SVC, IVC, our vena cava system, it's about 8 centimeters squared for cross-sectional area. So if it's inversely related to total cross-sectional area, that means the smaller the cross-sectional area, the faster the flow of blood, right? And indeed, doesn't that make sense? Because I always use that descriptor, whoosh, out of the aorta. So that should be hopefully a faster takeaway on that. And indeed, it is the fastest out of the aorta. And then it slows down as the further we get away, right? Because of peripheral resistance and all those factors. And then when we get into the capillary beds, one of the things that to realize, we no longer have a pulsatile flow. We have a chronic, slow, continuous flow through our capillary beds. And we're going to talk about capillary dynamics, how the fluid in our blood leaks into the interstitial spaces. And the fluid in our blood has all the good stuff in it, right? And it's going to the interstitial spaces where cells are working and they're making what I call the poopy stuff. And so they'd like a trade. Give me the good stuff and I'll give you the poopy stuff, and you'll take the poopy stuff back in the venous system to the organs responsible for getting rid of that. Lungs for carbon dioxide. Carbon dioxide, most people don't consider it poopy, but actually you get a lot of carbon dioxide off of a pile of poo. So carbon dioxide to the lungs, other waste to the liver and kidneys, right? Because isn't that what the kidneys are for? To help us get rid of our waste. So all of the bad stuff needs to be somehow taken from around our cells and put into the bloodstream so that they can be taken to the areas that actually takes care of them, right? Gets rid of them for us. Let's go ahead and take a look at the ways that we can regulate blood flow in an area. So we got velocity of flow, fastest in the aorta, slowest in the capillaries, and speeding up again in our veins. We have the organs and how much cardiac output they get. But what's really interesting is at our tissue areas, the areas that are needing oxygen and needing to get rid of carbon dioxide, they can regulate the flow in their vascular system based upon the amount of stretch they are actually undergoing. And this is referred to as the myogenic response. And what actually happens is when VVs are stretched, they contract. Previously, I told you about skeletal muscle. When you stretch a skeletal muscle, when you pull on it, your natural response is to contract, to jerk back. And we talked about smooth muscle, because isn't that what blood vessels have as their muscle lining? It's smooth muscle. And we talked about the stress relaxation response. But there are also little gates on those smooth muscles that will, when you stretch them, the stretching will open the gate, make the hole bigger, in other words, and cause an influx of ions, which will cause a contraction for itself. And that's what the myogenic response is all about. The blood vessel is getting stretched, and so the muscle says, whoa, we shouldn't be stretching this much. We should be actually at this volume so that this amount of blood is flowing into our tissue areas. So BVs are stretched and they contract with this system. So areas can regulate the amount and speed of blood entering the area. a drop of blood flow will actually cause an opposite effect. So decrease blood flow causes opposite effect. Auto-regulation. Now that means we can regulate ourselves, and this will be due to changes in local metabolic activity. So the more metabolically active the tissue is, what more or less carbon dioxide will be produced? More. What will happen to the tissue pH? It goes down. That's what this is actually all about. So the more metabolically active the tissue is, more carbon dioxide it's producing, the drop in pH, and this is where that autoregulation comes in, because the tissues say, acidosis is not good for me. And so I need to actually have you open up the plumbing so that I can flush this acidosis out, get the carbon dioxide levels down, and get my oxygen levels up. So that's autoregulation. Needs not being met so pH drops because of increased carbon dioxide, plus buildup of various other toxins. This will provoke vasodilation. Vasodilation, you know, open up the blood vessels and you're trying to have more blood flowing into an area. And that should make sense. Vasoconstriction, decrease blood flow into an area. Vasodilation, we want more blood to actually flow into an area. Autoregulation can be seen to actually bring about a phenomenon called reactive hyperemia. So reactive hyperemia, hyper is more, emia is blood flow to the area, and it makes the area look really red. And the best example of reactive hyperemia that I can give you for a visual that you can remember is take a rubber band and put it around your finger a lot. Make it nice and tight and leave it there. What will happen after a while? Finger gets pretty pale, doesn't it? And starts to not feel so good. And it's not feeling good because what do we know about the pH in that area? pH is dropping. What do we also know about toxin buildup in that area? It's going up. And then, you know, your mom's, you know, when you're a little kid, you did dumb stuff like this all the time for, I don't know why we do dumb stuff when we're kids, but we just do. We're experimenting with the world, aren't we? Making our own experiments, seeing what will happen, you know. So then you take the rubber band off of your finger and your finger turns cherry red, doesn't it? That's reactive hyperemia. So we've got a large amount of toxin in that area, and we are going to whoosh, put a whole bunch of blood in the area, do our best to actually clear it out. Blood flow in some very special areas. Skeletal muscle, blood flow varies with activity level, and at rest, remember it's only getting 20% of our cardiac output, our skeletal muscle is. And at rest, only 25% of the capillary beds are open and therefore being perfused. And this is under the regulation of the neurotransmitter norepinephrine. And remember, norepinephrine is a vasoconstrictor. And it's the sympathetic nervous system that's doing all of this still. And what will happen is you're sitting here at rest and your precapillary sphincters are closed in 3/4 of the capillary beds to your muscles. And also we're getting a little arterial vasoconstriction, and we're going to shunt that blood away from 3/4 of your muscle, but 1/4 of the muscle is getting adequately perfused. And then I say, oh, I feel really good. I've got my oxygen fix. I can hold my breath now. And so then that area will then be told to vasoconstrict, and another area will be told to open up, and that area will be fleshed out, and that area will go, I can hold my breath now, and that goes all the way through the muscle tissue. So it's a very interesting process. That's at rest. Do you think this applies to when you're actually actively exercising that tissue? Oh, the amount of perfusion to that muscle tissue goes up, and it's called exercise hyperemia. We can increase the blood flow in response to our demand. If we are exercising, we are going to demand more oxygen. We are going to be producing more carbon dioxide and various metabolics. And so we will be able to have auto-regulation overriding sympathetic control. So that's why you can still have norepinephrine being delivered to the capillaries in this area and the arterioles, and it doesn't matter, well, because we are exercising and producing so many other waste products, vasodilation will actually occur even in the presence of norepinephrine. Previously, I told you the brain's a hog. It loves a constant blood flow to it. And it is the one area in our body that has the most precise autoregulatory system. It wants near constant blood flow, even with activity. And carbon dioxide, however, is going to play a very large role in the autoregulation of the brain. Because when we have too much carbon dioxide, so increasing CO2 means we are dropping our blood pH, which our brain doesn't like, and it says vasodilation. You guys know what happens to people who have head injuries that are in the intensive care unit on a ventilator? Do you know what they're doing for them? Their respiratory rate? Their respiratory rate is actually elevated on the ventilator. And why are we elevating their ventilatory respiratory rate? Because if we let it be normal or low normal, we will get vasodilation. And if we up the respiratory rate, we will get the opposite, vasoconstriction. And when you have a brain that's been damaged, does it swell? Would you rather have a little vasoconstriction versus vasodilation? The vasodilation makes the brain swell more, and so that's one reason why the ventilators are actually, respiratory rate is up, because they're trying to get them to blow off as much carbon dioxide as possible, because the brain goes, wait a minute, and actually causes the opposite effect, the vasoconstriction. So CO2 plays, and pH plays a big role on what the brain will actually dictate for its own circulation requirements. Our skin, oh man, let's see here. Sympathetic stimulation indeed absolutely will cause vasoconstriction, and we have a whole bunch of anastomosis in our skin. Very, very extensive anastomotic system, and it's one of the reasons is because it's very helpful in creating efficient heat control radiator system for our blood. Let's take a look at the lungs. Arteries and arterioles are similar in appearance and construction to the veins of the rest of the body. And that's because this is the pressure they have to actually endure. 25/10. The body, remember 120/80? Big pressure differential here. When you're not working very hard, remember that right ventricle is nowhere near as thick as the left ventricle, and so are the arteries actually leaving that side of the heart going off to the lungs. So we have to realize that that is a system that it does make sense based upon the pressures they have to tolerate. When you have pulmonary hypertension, which is not a very common phenomenon, when you have pulmonary hypertension, that's actually referring to that pulmonary pressure going up, and those vessels are not structurally designed to actually handle that high blood pressure and can cause significant problems for an individual. Heart, indeed, when the ventricles contract, they compress our coronary blood vessels, stopping flow to the heart muscle when it's working. And that's okay because our heart muscle has a lovely store of myoglobin, which is our O2 reservoir. And so we use oxygen on the myoglobin when the heart is working, and then when the heart relaxes, we just reload up because now we have blood flow, oxygen's coming in, and we just reload our myoglobin stores. You guys realize that pulmonary pressure that I'm talking about is the arterial side of things. It's not the venous side, it's the arterial side, so it's going towards the lungs. Now comes the fun time. Capillary dynamics has never been easy for students. I don't know how to make it easy, but we'll walk through it. And I want you to understand pushing and pulling. So I said earlier in lecture, we have to get the plasma, not all the plasma, but some of the plasma from the bloodstream into the interstitial spaces because the plasma from the arterial side has all the good stuff in it. And we always think of oxygen, but there's other good things that are in there too. So oxygen is our main player. So arterial side, systemic circulation is bringing oxygen-rich blood to our tissue beds or capillary networks. We have to get the blood never leaves. Cells never leave the capillaries unless there's infection present. And so in order to get the nutrients to the tissues, we put the nutrients actually in a transfer medium, which is our plasma, and we let the plasma go into the tissues via the little clefts in the capillaries, and then it kind of flushes the tissues, and then we want that plasma at the end of the capillary bed to come back into the blood vessel, right? Because if we don't let the plasma that was at the end of the capillary bed coming back into the blood vessel, what will happen to the blood volume? It will decrease. And what will happen to the fluid volume in our tissue beds? Increase, and we get edema, correct? But this is the mechanism by which we feed our tissues. We have to create a fluid loss from our capillaries on the arterial side, and we have to bring the fluid back in on the venous side. Okay? So this is what capillary dynamics is all about. And there are two ways we can push the fluid into the tissue beds or not. And one of them is called hydrostatic pressure, and the other one is called osmotic pressure. So in our notes here it says fluid moves due to two opposing forces. So when I say opposing forces, I want you to understand when I talk about hydrostatic pressure comes from blood pressure, right? Remember we said that when we get to our capillaries, our pressure is 35 millimeters of mercury. That occurred because of the 120 systolic that the heart gave, and we went and got further and further and further and further away and smaller and smaller and smaller diameter, but we got down to an internal pressure of 35 millimeters of mercury. I want you to always equate that as to pushing pressure. Hydrostatic pressure is like filtration pressure. It helps to push the fluid out. Okay? Push the fluid out of the lumen of the capillary. That's hydrostatic pressure. And the opposing force means that we're trying to pull, if we're pushing out one way, the opposing means we're trying to pull the fluid back in. And that's what osmotic pressure is all about. So hydrostatic pressure is related to blood pressure. It's the pushing the fluid out of the capillaries into the interstitial spaces, and osmotic pressure is related to particles. right, in the fluid. And so more particles, the more water wants to move in that direction. And so I will often refer to osmotic pressure as a pulling pressure, because we're trying to pull the water where the particles are in greatest concentration. Isn't that what osmosis is all about? Movement of water from area of high water concentration to area of low water concentration. We really don't talk about that. We talk about the particles, right? Because high particle concentration means we've displaced water molecules, so we're trying to move water molecules in there to create an osmotic equilibrium in our tissues. So blood pressure is pushing pressure or filtration. Gravity's pushing fluid, right, through a membrane when we do filtration for the most part, yes? Yeah. So osmotic pressure is due to those non-diffusible substances in our plasma, which are typically proteins, plasma proteins, and it pulls water towards the area with the highest osmotic pressure, which means the highest particle count. Okay. So let's take a look here at this hydrostatic pressure story. The hydrostatic pressure will change will be different on the arterial end of a capillary bed than it is on the venous end of a capillary bed. And so that's, remember we said we come in at 35 millimeters of mercury and we leave at 15? So already, you guys follow me there? We're changing pressure when we do that. So capillary hydrostatic pressure, and in the notes it states we call it filtration pressure. It is pushing fluid from the capillary lumen into the interstitial spaces. Pushing fluid from capillary lumen into interstitial STI spaces. Remember, 35 millimeters of mercury on the arterial end of a capillary bed, 15 millimeters of mercury on the venial end of the capillary bed. Important to remember that. In the interstitial spaces, it's really kind of weird, these numbers. In the interstitial spaces, we have hydrostatic pressure because just by having water in a cup, it's the weight of the water, it's the force of the water, that is still some hydrostatic pressure. But in our interstitial spaces, this number can be really weird and quite variable. It can be a negative number, it can be 0, and it can be a positive number. And I chose to go with 0, which is weird because that number is basically telling you that the fluid is always drained from the interstitial spaces. Because even if we're putting fluid in there, ultimately it is being relieved. It is not found there. And so that's what an interstitial hydrostatic pressure of 0 actually means. It doesn't matter how much fluid we pull in to the interstitial spaces, the weight of that fluid is weight, and that's hydrostatic pressure. Somehow it's always being taken away. And that's a mystery right now for us to solve after we get to the end of this capillary dynamics. No fluid buildup in interstitial spaces. And can you follow me that opposing forces here will that the interstitial hydrostatic pressure will impact the capillary hydrostatic pressure because they're working against each other, pushing fluid in opposite directions. So if for some reason we did have edema in the tissues, would my interstitial hydrostatic pressure still be 0 if we had edema in the tissues? It would be a positive number. And the problem with that is the higher that number is, then the more fluid that will have a harder time pushing into the interstitial spaces. We'll get into that in just a moment. We have to always think about the interstitial hydrostatic pressure, and that's why we have this formula here. Net hydrostatic pressure is capillary hydrostatic pressure minus interstitial hydrostatic pressure. On the arterial end, it's 35 for the hydrostatic pressure minus the interstitial hydrostatic pressure, so it's still a positive 35. And I know that this is like, well, we're using 0, but I want you to realize that you have, right now, I want you to place that 0 in there, because if I say that there's swelling in the interstitial spaces, I want you to realize you have to change that number to a positive number. And on the venial end, our hydrostatic pressure is 15 millimeters of mercury. Now let's talk about osmotic pressure, which is an opposing force to hydrostatic pressure. Hydrostatic pressure pushes fluid, and osmotic pressure pulls fluid towards it. Our capillary osmotic pressure, we're lucky on this one, it's actually 25 on both ends of the capillary. So on the arterial end of the capillary, it's 25, and on the venial end of the capillary bed, it's also 25. However, when we look at the osmotic pressure, the particle pressure in the interstitial spaces, we actually do have a number here for a change, and it's 5 millimeters of mercury, and it's the same on both ends of the capillary. So it's the same on both ends of the capillary for capillary osmotic pressure as well as interstitial osmotic pressure, so we don't have to do 2 formulas, we just do 1. So that would be 25 minus 5, which equals 20 millimeters of mercury for our net osmotic pressure. And now we go and talk about the direction of fluid movements. Net hydrostatic pressure minus net osmotic pressure on both ends of the capillary. A, arterial end of the capillary. We already decided our hydrostatic pressure was 35, correct, from our previous calculations above. And it's hydrostatic pressure is pushing the plasma into the interstitial spaces, and osmotic pressure, because of particles that we have in our bloodstream, is trying to pull plasma back in. So that's what, because this number 20 here was that. So minus 20 equals, as our notes here say, 15 millimeters of mercury. So when you see that number, you do know that 35 is greater than 20. So 35 is pushing, osmotic is pulling, and so do we get a net fluid loss into the interstitial spaces, or do we get a net fluid gain into the capillary in this area? A net fluid loss into the interstitial spaces. Because if we're pushing into the interstitial spaces more than we are pulling it back into our blood vessel, that means we're having a net loss, right? 35 is the hydrostatic pressure. And 20 is the osmotic pressure. So that's basically telling you we're getting 15 units of fluid loss into our interstitial spaces, which is okay because isn't that fluid with the nutrients and everything? We want it in that area. We want our good stuff to go into the interstitial spaces so that we can refresh the interstitial fluid around our cells with oxygen, because the cells are low in oxygen, right? And now our interstitial space is high in oxygen, so we'll be able to have simple diffusion across the cell membrane of oxygen in. Cells are always highest in the production of carbon dioxide, yes? And so carbon dioxide will be high in the cell, low in the plasma on the arterial end of the capillary, correct? So we'll have simple diffusion of carbon dioxide into the interstitial fluid. Well, we need that fluid that's bathing and refreshing the cells. We need to now pull that stuff back into the venial side of the capillary. You guys follow me on that? So that's where we have our venial end of the capillary story. So we have 15 minus 0. That's net hydrostatic pressure on the venule side of 15. And we said our net osmotic pressure from up here above, right here, was 20. So we're going to minus 20, and that's going to give us our negative number, negative 5 millimeters of mercury. All of these numbers are actually in millimeters of mercury, everything that we've talked about, except for beats per minute. If there's any pressure associated with it, it's millimeters of mercury. So on what this is telling you, on the venule end of the capillary, we have 15 units of hydrostatic pressure pushing plasma into the interstitial spaces, but we have 20 units of osmotic pressure pulling it back in. So we are having a net movement out of the capillary or into the capillary? Into the capillary. So when we talk about capillary dynamics, remember the positive number is moving out of the capillary, and therefore the negative number is moving into the capillary. But this is a problem, isn't it? Because shouldn't it be the same number? It should be, because it would cause tissue edema, wouldn't it? If we actually didn't do something about it. And that's what's absolutely fascinating, because this is what capillary dynamics is all about. We're always losing more fluid into the interstitial spaces than we are pulling back in our capillary bed. So then how come we don't swell up? The reason we don't swell up is that there is another system that is designed for overflow, and that's your lymphatics. Right? Does anybody know of somebody who has had breast cancer and had a lymph node dissection? So they've had maybe a mastectomy, and then they've had a lymph node dissection to see if the cancer has spread to the lymph nodes. That's what a metastasis is. It's spreading to the lymph nodes, and then will be able to spread to other parts of your body. And they'll do a lymph node dissection. Well, guess what the lymph nodes are attached to? Your lymphatic vessels. And so they are disrupting the lymphatic return to the heart, and the lymphatics are designed to drain this overflow. So all of our tissue beds, all of these capillaries in that we actually have, also have little lymphatics interwoven into their makeup that is designed to actually take the excess fluid and put it back into the system, take it out. And that's why women who have had lymph node dissection have a problem with what's called lymphedema. They even give it a very specific name for the edema that occurs in that extremity that's associated with that breast that they had the lymph node dissection in. Lymphedema. The only way you can get the lymphedema down is to walk like this all day long and have gravity help you get the lymphedema down. Or you can actually literally massage the extremity and literally milk the fluid back into the vascular system with them. But that's difficult to do, and so they typically they've learned to live with their lymphedema, and then sometimes they do go around with their hands up in the air trying to get the swelling down. Yes?
Does the pressure immediately change when it crosses the halfway point, or is it gradual?
It's all a gradual shift. That's why we talk about the ends of the arterial end, which is the beginning of the capillary bed, and the venous end of the capillary bed. There's this transition, and it's going to...
so in the middle, is it like a limbo thing, or just...
No, yeah. So let's manipulate these numbers a little bit here. What happens when you exercise a lot? What happens to your hands if you've been wearing rings and you're exercising and jogging a lot? They swell up. Well, why are they swelling up? What is increasing? Because this is a capillary dynamic question for you. As you are typically swinging your arms, yes? When you do this, what will fluid want to do when you flick it out this way? So it's an increase in hydrostatic pressure on the arterial side, yes? So that means if we're increasing the hydrostatic pressure on the arterial side, we have a higher number than that, correct? So we're forcing more fluid into the tissue beds. And so if you, and especially if you let your arm swing down to the side with gravity making the flick even worse, the only way that you can actually help overcome that, because you'll come home and there'll be some slight swelling, your rings will be tight, but over time it corrects because of our lymphatics. So they'll go ahead and pull it off. They have the time because they're not a fast system. Lymphatics aren't fast, not like the cardiovascular system. So then if we have swelling in our extremity, why do we elevate it? Which hydrostatic pressure will we impact? Well, osmotic will be if we have infection, but let's just say plain old swelling for a non-infectious reason, okay? We elevate the extremity because we are using gravity to help us pull our blood down into the venule side of things, correct? And aren't we making it harder for the pressure on the arterial side to, aren't we making that arterial pressure kind of lower? The hydrostatic pressure is a little lower as it's having to, we're going uphill, correct? If we're going uphill, that's going to create some resistance, and our 35 suddenly becomes maybe 30 on the arterial side, which means then again we have less fluid actually leaking out into the interstitial spaces. And aren't we making it easier for the fluid to actually flow into the veins? And in the venule side, we will actually be able to get maybe a little bit more because we have it elevated and we're letting gravity help it flow faster. And so we'll end up with a reduction of this number. And so we'll have less fluid in the interstitial spaces. That's where I'm going to stop right now. I think it's a good place. On the upcoming exam for next week, we're going to have just a little bit of lecture included in that talks about lymphatic capillaries and blood vessels. So it's about a page or two of stuff, and I'm not going to create an extra lecture for it. So we'll talk about it on Tuesday, but realize the lymphatic capillaries are the overflow system that's going to take the blood back to the heart and on the venous side of things too.